Hi, Terry.
Hello, everyone. Thank you all for joining. This is, I believe, our third Solara Grand Rounds. And really, again, our purpose, our objective is to really give you a little bit of insight into some of the why behind the what. We've talked about perinatal transition, we've talked about periviability, and today we have our guest speakers, Terri Russell. Terri is a very experienced nurse practitioner with our team here in Phoenix. She has tons of experience at various level NICUs across the country. She's very involved with the AAP and has done work even with the AAP jaundice and phototherapy guidelines in the past. But today, Terri is going to talk about umbilical cord management in term and preterm infants. This is a very hot topic, something that you all are probably maybe have some variability within your units place to place. And so, what is the evidence? What is the why behind the what that we're doing? And I think Terri is going to do a fantastic job sharing a little bit of that. So, with that said, Terri, we have about, it looks like 20 plus people in the room here. So, the court, or I guess the presentation, is yours.
Great. Thanks so much, Dr. Agarwal. I appreciate that. I appreciate the opportunity to talk today. I was thinking about it earlier. I'm like, oh, I think I'd rather speak to a crowd of total strangers than many of my colleagues that I know, but hopefully I can share something that's new today, and we'll have a little time to talk about how we might apply this to our current practice. So without delay, let me get the right mouse. I am at work. Hopefully, I've asked them all to not call me unless it's a dire emergency. This morning, this morning we got called to a code stork at the main entrance, and so everybody goes down there. We're in the ED, and it was kind of total chaos, and they're just kind of running the mom around the ED in the wheelchair. And so I caught up to them, and so when I walked around to look at mom, I'm like, oh, she does not look very pregnant. So I said, hi, you know we're here to help you. I said, how many weeks are you? And she's like 19 and 6. And I was like, oh, I'm so sorry. But for a minute, I kept thinking, oh, great. I'm going to get a 23-weeker now. This is going to like blow up my whole day. But sadly, there wasn't much that I could do for her. So, okay, so let's get started. I always think it's good to reflect a little bit on history. Um, the correct timing the correct timing of umbilical cord clamping for newborns has long been debated in obstetrics. And as you can see, even back in the 1970s, um, there was a comment by Charles White that the common method of tying and cutting the navel string in the instant the child is born has nothing to plead in its favor but custom. So, and I think, many times we can still kind of relate to that today. We definitely try to practice evidence-based care, but we do fall back on custom sometimes. So I do think a good amount of what we do is still witchcraft. Okay, so in the 1800s, there was another comment made that another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but till all pulsation in the cord ceases. So Erasmus was definitely onto something. In the 1940s, there was concern expressed about anemia as a complication of early cord clamping. And now we fast forward a couple decades, and in the 60s, there was kind of a shift with the management of stage 3 labor, which was delivery, concern about postpartum hemorrhage, and things that could reduce it. This was also the time that Virginia Apgar um, gained interest in caring for newborns, and she had implied that keeping the cord intact contaminated the sterile field, and delayed clamping was deemed part of a slow delivery. And that slow delivery somehow meant that it was unwise or unnatural. So just a little more. Now, you can see on your left-hand side, these are some definitions of early and late clamping, and you can see there's variations in times, which we still are wrestling with today. Probably, oh, so as modern obstetrics kind of came into being, there was an increase in C-section deliveries. Um, so OBs, wanted to be efficient and finish their work in a timely manner and take care of the mom. So that didn't really bode well with delayed cord clamping. Also, there was an increased use of narcotics and general anesthesia. And so, there was some anxiousness about getting babies delivered before they had too much exposure to either of those, with an increased risk of apnea. So then in the early 2000s, there became this growing momentum for delayed cord clamping, and that was primarily started by midwifery. So, and it's kind of interesting because when Dr. Woods asked me to present on this topic, I immediately thought back to, I think it might have been like 2004-ish, 2005. I was teaching at Rush University in Chicago, and I was asked to speak at a national midwifery conference on neonatal resuscitation. So, I mean, I was giving it a lot of thought, and then one day I ran into actually um, my department chair was a midwife. She was incredible scientist, but she was a midwife by training. So I was like, hey, Jan, can you give me some ideas about what midwives would want to hear about with neonatal resuscitation? Because, I've always been a NICU person. And so that's kind of where my head goes. And she said, I think you should spend a good amount of time talking about delayed cord clamping. And I was like, what the heck is that? Like, why would anybody want to do that? Because I'm thinking about resuscitation and stabilization. And anyway, I kind of started delving into the literature then. And of course, there wasn't a lot. And so when I went to the conference and we talked about it, I offered a lot of cautionary advice, like we don't know what the potential complications are. We need to like move slowly with this. And, they almost all booed me off the stage, but whatever. Anyway, so then in 2009, there was a survey that indicated about half of OBs practiced delayed cord clamping and about 40% had never done so. So we're moving along. I put together this menu today for you on cord management options that we now have, and we're going to go through each of them. We're going to touch on each of them. There's a lot to say. There's a plethora of literature now. So first of all, immediate cord clamping, which is what I think we're all familiar with, is considered clamping of the cord immediately or within the first 15 to 20 seconds. And I'll just say that, like, when I first became a nurse, um, our cord clamps were not like the plastic cord clamps that we have now. They were metal ones. I don't know if anybody else recalls those, but that is definitely a change that I've seen. So delayed cord clamping is waiting for anywhere from 30 to 180 seconds. And that definition in itself presents some problems, which we'll look at. Now we have physiological base cord clamping. So that is when there isn't a finite amount of time that we're waiting to clamp the cord, but rather looking for some physiological stability. Um, some physiological stability, so the baby has a good heart rate, has has spontaneous breathing, and just looks like the baby's improving and transitioning before cord clamping happens, and that can be several minutes. Now we know about intact cord resuscitation, or in some papers, it's called NRIC, which is neonatal resuscitation with an intact cord. So this is where respiratory support is provided if needed for a baby who is breathing either ineffectively or is apneic. And so that we begin to provide oxygen or ventilation or both before clamping of the umbilical cord. And as we'll see, this definitely kind of opens things up for us when we look at our preterm population. And then umbilical cord milking is not like a passive transfer of placental blood, but rather the cord is gently squeezed and pushed toward the newborn 3 to 4 times um, after birth. So generally that process takes only about 20 seconds. And this is something that I saw like back in the day when I was a new nurse. We had one obstetrician that would put the baby on the table in the delivery room and do this. And the kids were they always looked so plethoric. I was like, I don't know. I don't think that can be good. Anyway, what goes around comes around. So we're seeing this, and then we'll kind of talk about things that we need to be aware of. Uh, I'm looking for our first question. Oh,
All
okay.
right. Yeah, I can launch the question right here.
Okay.
So the question is, what is the amount of placental transfusion term infant receives with delayed cord clamping? 30 to 45 mLs, 50 to 75 mLs, 80 to 100 mLs.
Take a second, think it over. I think your answers are anonymous.
All right, we have about 5 responses back. We have about 8 responses back now.
All right. Oh, a
All
couple
right.
more.
Yeah, 13 responses. All right, well, we can finish this up, and Terri, I know you're going to be addressing this, so I'll let you continue. But yeah, 14 responses, of which 36% said 30 to 45, 43% said 50 to 75, and 21% said 80 to 100.
Okay. Thank you. All right, let me move forward. So the current standard now is for increasing placental transfusion at the time of birth. You can see over on your right, there's a couple pictures of umbilical cords that are made out as hearts. I will warn you, this is not the only heart picture of an umbilical cord that you're going to see. But you can see on the left, you can still see a lot of blood in the umbilical cord. This is a baby whose cord was clamped immediately versus a baby with delayed cord clamping, where the umbilical cord looks white because the baby's received an adequate placental transfusion. All right, so even though we know that placental transfusion or delayed cord clamping is desired, there's certainly still some issues with the general compliance on the part of staff, providers. So something that I think we probably need to do a little deeper dive into. So the continued flow of blood in the umbilical cord after birth is known as placental transfusion. And this transfusion is thought to be, or is known to be, somewhere between 25 to 35 milligrams per kilo of blood in the first 1 to 3 minutes of life. So if you do your math, the answer that we come up with in terms of the amount of blood that a term infant receives is actually 80 to 100 mLs. So there's thought to be a 30% increase in blood volume and a 50% increase in red cell volume, which is particularly important when we talk about the quantity of iron that a baby's getting. They're getting a lot of iron that is then stored as ferritin, which we'll talk about. And this reduces and prevents iron deficiency in the first year. And that also has some important implications. Okay, so here's another umbilical cord with a heart. And it's, can you see the word? Love. I was like, okay, well, this is like we could do this like while we're waiting for delayed cord clamping. I don't know. I thought it was a cute picture. So about half of the fetal placental blood volume is in the placenta in the preterm baby at delivery. So about half of their blood volume versus in a term baby, 2/3 are in the baby and about a third of the blood volume is in the placenta at term delivery. So if we think about it, that means that it may take longer for a preterm baby to have an adequate placental transfusion compared to a term baby. We also know that uterine contractions, especially during that third stage of labor when the contractions are very hard and long, that uterine contractions can assist with the placental transfusion. So in the absence of labor, like a scheduled C-section, there'll be less placental transfusion prior to delivery. This is just another little picture to kind of demonstrate the differences over time. So you can see the white baby is the baby that has had no placental transfusion, and then around 2 minutes, and then at somewhere between 3 and 4 minutes. So they have the estimate at 50 to 100. And then you can see on the top red line that the baby's infant blood volume starts at around 75 mLs per kilo, and with improved placental transfusion, their blood volume is probably closer to 100. So the placenta gets white as the baby gets an increased amount of blood. Okay, how about, can we quickly do the next question
Yeah,
then?
yeah. All right, so the question is, what is the remaining concern with delayed cord clamping? Polycythemia, which I believe I misspelled, my apologies, delayed resuscitation, and postpartum hemorrhage.
So
So
pick one.
which one do you think is still something we're worried about? It gives everybody a little bit of pause. All right, we have about 10 responses so far. Half for polycythemia, half for delayed resuscitation. 13 responses, about 54% delayed resuscitation. All right, well, it's about
Okay.
50-50. Polycythemia and delayed resuscitation. Take it over, Terry.
Um, so there have, in term infants, there have been numerous multiple systematic reviews with meta-analyses of randomized controlled trials that have demonstrated safety, the safety profile of delayed cord clamping. So as you know, like systematic reviews are considered a very high level of evidence because they not only pull all the data from individual studies, but they conduct their own analysis as well. So thought to be very helpful and reliable in terms of creating the evidence-based practice that we all desire. So these studies have shown that well, that we see that the potential problems or concerns are increased hyperbiliary and polycythemia. Those were very early, like, and as we started seeing more delayed cord clamping, delayed resuscitation, if a baby isn't transitioning appropriately, and then reduced effectiveness of cord blood banking. I'm not sure, like, I honestly, I don't know that I've ever seen a baby with cord blood banking, like, since I've been working out here. It seemed to be a thing maybe like around 2010 or so, where parents could buy a kit, bring it to the hospital, and then we would collect the cord blood for them, which then went into storage, because of its amazing, stem cells, to be used down the road for a family member should it be needed. It's costly, and there's like an annual storage fee. I don't know what other people's experiences, but it seems to have fallen a little bit out of favor. So there was a lot of early concern about that. So, and there is no evidence to suggest an impact on neonatal mortality or severe morbidity in term infants. So what we know is that, there there may be an increase in, well, there is in some studies an increase in the absolute, bilirubin number, but many studies have shown that it doesn't increase the need for phototherapy, and definitely there's no increased need for, exchange transfusions. Polycythemia, kind of more of the same, that babies tend to have higher H and H's, but the concern with hyperviscosity, is not increased, and these babies do not have an increased need for partial exchanges to reduce their red blood cell volume. So the answer to the question is really delayed resuscitation. And it's, kind of, there's been a quandary about what to do, knowing the benefit of delayed resuscitation. But if the baby is not responding, not breathing, then the only choice is to abandon placental transfusion. So other things that we know about delayed cord clamping is that there's not only an increase in blood volume, but also an increase in ferritin stores. So ferritin is the major iron storage protein in the body, and it's very important in for infants to continue to make red blood cells to have that storage pool of iron. Um, Oligodendrocytes are known to be very sensitive to iron deprivation. So it's not just a matter of anemia in these babies, um, but the fact that, these oligodendrocytes, help with, myelin production. And this is very important, especially in regions of the brain that help with motor function, visual and spatial skills, and sensory processing skills. So this study that I have listed was a study that was done that looked at 4-month ferritin levels. They looked at myelin maturation using a special, MRI, and then they also did neurodevelopmental follow-up. So they found that, definitely the ferritin levels were much higher, helping to prevent anemia, and that, there was increased myelin content in the regions that I previously discussed. Um, so, um, so actually, very potentially very important for neural development. The problem with a lot of these studies is that they end up losing a lot of patients to follow up, and then the expense, but they were able to look out at 12 months. So also I just want to mention that it's not just blood that is being transferred, but remember, placental blood has, millions of stem cells that are really important. Some are undifferentiated. It can differentiate into different cell lines. Others can differentiate into their own cell lines, but very beneficial. And as well as the immunoglobulins after their cellular injury, inflammation, and organ dysfunction. So when we think about that, I mean, all babies can benefit, but certainly our preterm infants that are exposed to many interventions that cause these things to occur, it can be potentially very protective. So, in terms of neonatal resuscitation, the 2010 International Liaison Committee on Resuscitation, which is called ILCOR. So it's an international group of persons that are representing different countries and reviewing the current literature on resuscitation. So in 2010, they stated that cord clamping should be delayed for at least 1 minute in babies who do not require resuscitation. And evidence was insufficient to recommend a time for clamping if they did require resuscitation. And then it wasn't until 2015 that delayed cord clamping was formally introduced and recommended in the NRP program. So many people had been doing it prior to that, but their recommendation was for at least 30 to 60 seconds. Now, the ninth edition of NRP has been released like in November of last year. And I don't know if you can see this. This is the algorithm for resuscitation, but you can see like the third step now is initiating your cord management plan. So it's not just delayed cord clamping, but have a plan in place that you're going to follow once the baby's been delivered. And then we'll look at a couple other aspects of NRP kind of as we move along. So in terms of safety, which we looked at some of the aspects, it's also been shown on the OB side that there is no impact on maternal postpartum hemorrhage or the need for a maternal blood transfusion, which was a very early concern, as we saw, looking at the history. Also, things that we know is that there is no adverse effect on APGARs, increased need for resuscitation or intubation, and or lower levels at admission to the NICU. There certainly are individual studies that have shown a lower temperature on admission, but with good quality improvement, that we have been able to correct so much of that. So moving on to preterm infants, there are, again, a plethora of studies. This particular Cochrane review, which is a really rich database for systematic reviews. This was a study, or this was a meta-analysis of 48 studies that involved close to 6,000 babies. And they ended up having data on almost 5,000 babies that were 24 to 36 weeks of gestation. They showed that delayed cord clamping decreased mortality by a significant margin, 30%, that there was also a reduction in the relative risk of any IVH. Although it did not show that there was a reduction necessarily in severe IVH. So, and then they also looked at early cord clamping appears to lead to more baby deaths when compared against either delayed cord clamping or intact cord resuscitation. So as you can see, we're kind of moving toward a state where one has to really question whether it's even ethical to have early cord clamping as a part of any study now. So many trials in this review excluded babies that required immediate resuscitation if at birth because they were just delayed cord clamping trials. And so if a baby came out and needed resuscitation, they were clamped and then sent on to the neo providers for stabilization. And what they found was that if the babies were allocated to delayed cord clamping but needed immediate resuscitation, they did not receive the intervention and sometimes were excluded from the um, analysis of outcome or um, the intent to treatment. So within this meta-analysis, there were a lot of problems because there was a wide variability in the methods and definitions of early and delayed cord clamping. And some studies, they used early cord clamping up to 30 seconds and then delayed cord clamping right after 30 seconds, which may have or probably reduce any difference in observed outcomes. So, and different studies looked at different interventions and outcomes. So, while systematic reviews can be very helpful, just because of the lack of uniformity, it became very different or very difficult to tease out um, improvements that may really be there. This is another randomized control trial, or this is another meta-analysis of 18 randomized control trials. And a couple things of interest is that they showed that there was a that the delayed clamping group reduced all-cause mortality before discharge. And as you can see, this is statistically significant at 0.005. There was reduced mortality for infants less than 28 weeks and had an increase, babies had an increased hematocrit in the first week. There was also a significant reduction in the proportion of infants that required blood transfusions, and that was like significant to 0.00001. So very important. Um, and they also demonstrated that when babies were held at increasingly low levels below the level of the vagina or the introitus or C-section, that there was more placental transfusion. So you might ask, well, how did they know how much there was, right? Because it's not like you have a measuring cup that you're measuring. And so if you think about, well, how do we look at urine output in the NICU? And, you know, generally we weigh diapers, right? So like, I always think like the old adage, a pint's a pound, the world around. So if, and we can do the same with weight. So they would actually weigh these babies at delivery and then weigh them after the delayed transfusion was complete to get an estimate of how much blood volume the baby received. So they do estimate based on this that annually there's about 1 million infants less than 28 weeks. And honestly, I can't remember if this is just in the United States. But if we used delayed cord clamping, if we could achieve delayed cord clamping in more of these low birth weight infants at less than 28 weeks, that we could achieve somewhere between 10 to 90,000 additional survivors a year. So something to ponder. All right, so just I wanted to talk a little bit about physiology with delayed cord clamping. And I know there was that we recently had a grand rounds talking about transition. So hopefully you have, and I always say if you don't have good knowledge of fetal circulation, you should really take the time to learn it because it's so important when you're taking care of babies with congenital heart disease or babies with, um, you know, hemodynamic instability. it just makes sense. So remember that blood returns from the placenta to the fetus via the umbilical vein. So the umbilical vein carries the most highly oxygenated blood, which is still not highly oxygenated. I think they're the sats in utero, and anybody correct me if I'm wrong, I think is between 50 to 60%. I know their PaO2s are generally in the low 30s in the umbilical vein. So that most highly blood enters the returns to the baby via the umbilical vein, where the ductus venosus is encountered, and then into the IVC. And as blood enters the right atrium of the heart, the inferior vena cava is positioned in a way that it can shoot across the patent foraminal valley between the right and left atrium. So even in fetal circulation, this most highly oxygenated blood is preferentially shunted across the PFO into the left heart. So even after delivery, now the baby continues to get a good amount of um, systemic um, uh, systemic blood into their left atrium, left ventricle. Because remember, normally, well, the lungs and the fetus is collapsed, and very little blood goes through the pulmonary artery during fetal circulation. So even at the time of delivery, there's a delay in decreasing that pulmonary vascular resistance to aid in pulmonary blood flow. And there has to be pulmonary blood flow in order for um, the left-sided heart pressures to increase with the return of blood to the left atrium via the pulmonary veins, right? So there's four pulmonary veins that drain back into the left atrium. And that, quickly increases systemic blood volume, which then helps to decrease the amount of blood that's flowing right to left, and increase pressure. So initially, that placental transfusion helps support left systemic heart pressures, and while there is a decrease in pulmonary vascular resistance with increased pulmonary blood flow. So, I mean, it's really kind of fascinating that, and I think we've all seen babies who come out, they are born, they aren't breathing, their cord's clamped, and you can see, these babies have early signs of shock, um, because of that. So they have shown in lamb models in particular that when lambs are first ventilated and then subsequently clamped, that systemic and cerebral hemodynamic parameters remain stable. So it's so the need for ventilation, whether it be spontaneous or provided by us, is very important in the scenario of increasing left-sided heart pressures to support hemodynamic stability and improve blood pressures and a stable cerebral perfusion. So after that point, as the systemic pressures on the left side of the heart increase, there's less blood flowing across the PFO. The baby has received adequate transfusion, and then at that point, placental blood flow can be removed. All right, I hope that makes sense to people.
Terry, did you want to do this last question here? I think it probably was relating to that slide.
Oh no, did I forget it? Oh, I did. I'm
That's
sorry.
okay.
Sure, let's
This is
do it.
hopefully folks will be able to answer this here. So, placental transfusion during delayed cord clamping initially increases RV preload, increases LV preload, or has no effect on PVR.
All right, 100% guys, we should get.
We got a couple responses back. We'll wait for a few more. See if folks are still awake here. I'm sure they are. They're listening intentfully here. We got 4 responses so far. All have selected increased LV preload. All right, we got about 7 responses back, Terri. All have said increased LV preload, and I think that's exactly what you just mentioned. That jet that's kind of coming across the right atrium through that foramen ovale is really giving that um, LA and then LV some additional preload.
Great, thank you.
Thank you.
All right. So now let's just talk a little bit about intact cord resuscitation. Again, we're thinking about like, babies who um, you would really like to do delayed cord clamping with, but the barrier has always been if the baby needs resuscitation, then they get moved to early cord clamping and lack those benefits. So as we talked about, effective cardiorespiratory transition requires um, lung inflation, increased pulmonary blood flow, and increased oxygenation. Um, so we know that if there's early cord clamping before there's lung inflation, that this can result in increased left ventricular afterload, which then also increases blood flow through the carotid artery, which is really meant to be passive. And we remember we've talked about the problems with autoregulation in our tiny babies. So that increases the risk for IVH. All right. So supporting ventilation might really be an important key in cardiovascular stabilization um, as we're able to recruit alveolar expansion. This is a study of intact cord resuscitation. This was called the Vent First trial. And so they were looking at their primary outcome was a reduction in IVH or early death. And actually, the study did not show that. You can see over on the right in the Vent First babies that received early cord clamping that was kind of matched about half and half, unfortunately. Okay. So uh, now I just want to make you aware there are some delivery room equipment that are being trialed for babies to be able to have intact cord resuscitation. This particular thing is called a Life Start trolley. I think it was introduced in the United Kingdom initially. I don't know if it's ever made its way over here yet, but this is a way that we can be up close to the baby at the time of delivery, and the NEO team can be active in initiating resuscitation while we're awaiting that placental transfusion. So kind of an interesting device. It does have like a heated mattress, which I guess they've made upgrades to, but a lot of places are still using the thermal mattresses in addition. There's a camera so that providers can see what's going on if they're not able to get close. If there's a single person that's directly at the baby's bedside. This is for a vaginal delivery, and you can see how they have the baby over to the side. The issue with preterm babies is that their umbilical cords are generally much shorter, so you don't have a lot of room. You've got to kind of, be right close to the mom. So I don't want to go through these in great detail because I'm afraid I'm going to run out of time, but this is another trial where they did physiologic physiologically based cord clamping, and they looked for physiologic stability, which was a heart rate over 100 and SATs greater than 85. Babies with delayed cord clamping during this received up to like almost 6 minutes of delayed cord clamping. So, but this trial also did not show an increase in survival without major cerebral injury and or NEC in the entire cohort. There was also no differences in RDS, BPD, and ROP. All right. So I do want to talk a little bit about umbilical cord clamping. This is kind of an important trial to be aware of. This was done by Dr. Katheria, who's at Rady's in San Diego. He's been very active in delayed cord clamping studies. So they did a trial of umbilical cord milking versus delayed cord clamping in preterm infants. These babies were 23 to 31 weeks. They had they were planning to enroll about 1,500 babies in order to show a significance in decreased IVH and other primary outcomes. So this trial was stopped after the first 474 babies were enrolled because there was a signal of danger in the study that showed an increased risk of severe IVH in the 23 to 27 week infants. So something that will give you pause to consider. So I found this was interesting. So this is a theory about how cord milking can be dangerous in the very preterm infant. And you can see, so we talked about how you're supposed to gently milk the cord 3 or 4 times, but with active milking of the cord, you're not only compressing the vein, you're also compressing the umbilical arteries, and this leads to an increase in left ventricular afterload and also an increase in um, cerebral blood flow, again, because of the lack of autoregulation. So this is thought to potentially be what the contribution is to IVH with umbilical cord milking in the very tiny babies. So they did end up going on. They stopped the trial, then restarted it at 28 weeks and above, and that did not show any increased incidence. Okay. So this is the current NRP recommendation in terms of umbilical cord management for term and preterm infants. The recommendation now, as we said, is for a minimum of 60 seconds in babies, and that for non-vigorous term infants and late preterm infants, 35 weeks or more, that umbilical cord milking may be a consideration. But for babies who uh, but for babies who that cord milking, especially in preterm babies of less than 35 weeks, is not recommended. And this just shows the levels of evidence that are used to determine that.
And Terry, I think we had a question as well for this, but I can go ahead and launch it and just to solidify what you had just said. So let me launch that here. The question is, what is the recommendation for the current NRP recommendation for umbilical cord milking in preterm infants? So reasonable for non-vigorous infants greater than 30 weeks gestation, reasonable for non-vigorous infants greater than 33 weeks gestation, and reasonable for non-vigorous infants greater than 35 weeks gestation. So really, the question is asking, what is the gestational age recommendation for umbilical cord milking in preterm infants?
Right. So according to NRP now, it's not recommended for infants less than 35 weeks of gestation. So
Okay.
they're,
Yeah. Yeah. I
yeah.
just launched that poll. Sorry.
Yeah, I'm
You
sorry, I
answered the
forgot the
question.
question again.
Yeah, you're fine. You're good. I think everybody can submit those answers then, and be confident about that. So yes, just as you said, that's reasonable for non-vigorous infants greater than 35 weeks gestation, based on what you said. So thank you for that, Terry. I just wanted to squeeze that question in since
Yeah, no, I
you were
appreciate
on
it.
that slide. Okay.
So actually, and so well, and thinking like, because like we've talked about babies who are not exposed to labor have decreased placental transfusion, it seems like an appropriate population to do umbilical cord milking would be in those babies who are delivered, term babies who are delivered by elective C-section. That would be a safe alternative. And really in term babies, even born vaginally if needed, although delayed probably is priority. All right, so just a couple things, other things that I really want to talk about related to placental transfusion and oxygen. This is also another kind of important study. This looks at deferred cord clamping with high oxygen and extremely low gestational age newborns. So this was a study that was done. The mean gestational age was 26 weeks. They enrolled babies 22 to 28 weeks. There were 140 babies, and they were randomized to either 30% at the time of delivery, which is the current was the current neonatal NRP recommendation, or 100% by CPAP or PPV if needed. So, and then what they did was they put a pulse ox on them, and they measured what their 5 minute O2 sat was with each group. And then at 5 minutes, the babies were quickly titrated back to 30% or just turned back to 30% if they had been receiving 100%. So this is kind of just a nice diagram to show you that if you can see the orangish colors, the dark orange and then the light orange, these are babies that had O2 sats of um, definitely less than 8. So the goal was to have a saturation of at least 80% by 5 minutes. So you can see that the lowest gestational ages, 23 and 24 weeks, had the highest number of babies and with low saturations compared to the other gestational ages. And as we moved on to babies that were 26, 27, and 28 weeks, there were less babies with low saturations. So the importance of giving higher amounts of oxygenation is probably important. So 50% of these babies received delayed cord clamping, and about half of them did not achieve saturation target at 5 minutes of at least 80%. They also showed that a 5 minute saturation of less than 80% was associated with increased risk of death and or severe IVH, early death and severe IVH. So as you can see, there was for those babies that had one of those complications, that 23% were in the low 5 minute saturation group and versus 11.7% in the high 5 minute saturation group. So they just kind of enforce that um, that oxygen is probably extremely important in decreasing morbidity and mortality in our smallest infants. And I know for so long we have been cautioned about the concern of potential hyperoxia in this in our smallest babies, they have decreased oxygen radical scavenging systems and are at risk for, BPD and ROP and other problems. But the thought is with delayed cord clamping and administering high oxygen is that remember the blood that the is returning to the baby at delivery from the placenta is a low oxygen saturated blood, even though it's oxygenated, the sats are still really low. So now the baby's receiving that low oxygen saturated blood and receiving higher oxygen concentrations via PPV. And so the chance of overshooting and causing hyperoxia is really relatively low. And they demonstrated that there really wasn't an increased number of babies that flipped to 100%, again, because of receiving that lower sat blood from the placenta. So I think something, regardless of how we resuscitate babies at delivery, that increasing FiO2 is becoming of utmost consideration. There was another big study that was done that kind of led to the current NRP recommendations now that babies less than 32% or 32 babies less than 32 weeks need to have an FiO2 concentration of greater than 30%. So I know as a group, as our practice group, we should talk about what we want that to be. They, in their study, they did not standardize um, their initial respiratory support strategies, including the oxygen titration. So optimizing early oxygen support is definitely important. Just a
Hey Terry,
quick,
we have about 3 minutes. I just wanted to give t people some time to ask questions too. So do
okay,
you want to,
so I'll
if
leave
you,
this.
yeah, yeah, go ahead.
This is the list of babies where cord clamping may be not indicated. I think a lot of them make sense. I think if there's a question, it should be a team discussion. This slide just kind of gives an overview of some of the positive factors involved in delayed cord clamping. And this is kind of my last thought is that I think as we move forward, especially in resuscitating our smaller infants, but maybe even term babies who are in trouble, that as a neonatology team, we need to work to get closer to the baby at the time of delivery. Like, I mean, normally, like OBs, will definitely express, they get anxious, like if a baby is not vigorous at the time of delivery. So I think working on a plan where we can involve them and be, at the bedside, moving toward intact cord resuscitation, I think is something that we can certainly look at. There still is some caution expressed in the literature as they're kind of doing more. There's a few more studies that are out there, but certainly, if you think about, the potential harm of early cord clamping, that, um, doing intact cord resuscitation when we can would still be desirable. And I think this is my last slide. And I basically, although some of the outcomes have not been um, as um, robust as we had hoped. I think we have to realize that a lot goes on with our babies once they walk through the NICU doors. That, we're saving their lives, but we're also doing a lot of interventions and treatment that have the potential for, um, significant adverse effects. So I just say that I think like as we think about the intent that we want to provide in the delivery room with these babies is the same intention that we should show every day, that when we show up to provide care for these babies. So, whether it be monitoring their PCO2 or their temperature or blood pressure. I mean, all of this is kind of a giant or pieces to a giant puzzle. So certainly providing a strong foundation can be very important in moving forward as we care for them. Okay, so sorry. Thank you.
Yeah, thank you. Thank you so much, Terry. I know we're right at 3 o'clock, but I do want to give an opportunity if for any questions that folks want to raise their hand for, or put in the chat. I know we had a few questions through the polls, but yeah, anybody have any questions or thoughts?
I guess like I'd like to know if do individuals have a different thought about cord clamping after listening to the information than maybe you did before? Or is it Friday afternoon and everybody's checking out?
I thought it was a great talk, Terry. Thanks so much. It's Sean Woods. I wondered if of the things you presented, which of the things was like new to you? What's the most newest takeaway in terms of the evidence around delayed cord clamping, or the most like surprising, or like what did you find to be kind of the most important takeaway?
Oh, you're asking me?
Yeah.
Yeah, I definitely think the discussions about intact cord resuscitation, the
Mm.
papers are very important, because really the only option if you don't do intact cord resuscitation is early cord clamping. And I think it's really been, well demonstrated that physiologically is really not supportive to our patients. That, and then I think just kind of reiterating the importance of oxygen in the delivery room for these tiny babies, um, that while it's important to follow their SATs closely, that the risk of hyperoxia is low, but the risk of mortality is high if we don't move their saturations, to that 80 to 85% mark at 5 minutes.
Terry, I found that physiologically, it was a light bulb moment for me. If you think about how you described the transfusion as being it is relatively desaturated blood, PO2 in utero 20 to 30, right? So we're kind of diluting the oxygen saturation of the baby by transfusing with, relatively hypoxic blood, right? So
Right.
um, now perhaps oxygen demand that the baby sees, 30%, 40%, whatever we give, has less kind of generalized impact if more is now being bound to hemoglobin and not, not truly just oxygen content or O2 in the blood, causing free radicals. I mean, just that concept, I don't think I've thought of it that way. So I appreciate you explaining it in that manner so that we can think about the physiology of the transfusion, not just, oh, transfusion, all blood is the same.
Right. Agree.
Yeah. All right. Well, it's 3:03. Some great comments here as well. Um, Folks are interested in following research of intact cord resuscitation. Definitely, seeing more delayed cord clamping and all of that here in L&D from an L&D nurse. And Kim talked about some OBs doing vigorous milking. I know there are some stylistic differences there that perhaps we need to do some education on as well. And unless you have other thoughts on vigorous cord milking, Terry, have you seen that
Oh
or heard
yeah,
that?
I do see there's one OB that comes to mind, but yeah, it makes me really nervous. So I do think it's a conversation that we should bring forward, just in terms, we could do it as an umbrella of umbilical cord management and delayed cord clamping, that now the NRP recommendation is for a minimum of 60 seconds. Because it just seems like now, to me, 30 seconds just seems like, what is that? So I think if we kind of work with as a team to and again, like, if that means, like, being right there with them and monitoring the baby, I think that might be really helpful. It would be interesting to see what their takeaway is, or what they feel like they need, what support they need.
Yeah. Well, thank you again, Terry, for taking us through this journey of umbilical cord management. I think it's such a hot topic, and you did a fantastic job just really talking about the various aspects of it. And I think we learned a little something today, so appreciate your time. Appreciate everybody joining. And next month, we have a guest speaker from a different facility, different state university, who will be talking about, I believe, respiratory distress and surfactant. So keep tuning in, and thank you all for joining. Happy Friday.
Thanks so much, everyone. I appreciate your time.